Hello. Today we will be talking about grief and loss. This concept can be found in your MedSurg book. Let's look at some of our objectives. Okay, bear with me here. So, number one, identify a nurse's role when caring for the client who is experiencing loss, grief, or death. Number two, describe the type of loss experienced throughout life. We're going to identify types of grief, describe the characteristics of a person experiencing grief, discuss the values that influence a person's response to grief, develop a nursing care plan for a client and family experiencing loss and grief. We're also going to identify ways to collaborate with family members and the interprofessional team to provide palliative care, describe interventions and symptom management in clients at the end of life. We're going to look at criteria for hospice care and describe the care of the body after death. This next slide is just a comparison between hospice and palliative care. The information that will be covered again, all of this information will be coming out of your MedSurg book. Overview, death, dying, and end of life. So, dying is often feared as a time of pain and suffering. However, it's part of the normal life cycle. For the family, death of a family member is a life-altering loss that can cause significant and prolonged suffering. As sad and difficult as death may be, the experience of dying need not be physically painful for the patient or emotionally agonizing for the family. The dying process can often be an opportunity to change a difficult situation into one that is more tolerable, peaceful, comfortable, and meaningful for the patient and the family members left behind. I will refer you to Table 8.1. In your book, it lists the most common causes of death in the United States. And just to point out, of all the people who die, only a small percentage of them die suddenly and unexpectedly. Most people die after a long period of chronic illness, and those are examples have been mentioned in the book. Many healthcare providers oftentimes view death as failure. These views have led to major deficiency in the quality of care provided to many at the end of the life, and multiple barriers still remain, often related to the reluctance of the patient, family, and healthcare providers to stop treatment when end of life is near. So let's talk about the patho of dying. Death is defined as the cessation of integrated tissue and organ function, manifested with lack of heartbeat, absence of spontaneous respiration, or irreversible brain dysfunction. It generally occurs as a result of an illness or trauma that overwhelms the compensatory mechanisms of the body, eventually leading to cardiopulmonary failure or arrest. So, some of the direct causes of death include, and all of those are listed in your book. For example, acidosis, hyperkalemia, tissue ischemia. Dramatic changes in vital organs can lead to toxic metabolites or metabolites and destructive enzymes referred to as multiple organ dysfunction syndrome, or MODS. As illnesses or organ damage progress, the syndrome occurs with renal and liver failure. Renal and liver failure can also start the dying process. Comfort concept is going to be an exemplar, and we're going to look at end of life. The American Nursing Association and Hospice and Palliative Nursing Association, known as HPNA, supports the nurse's role in advanced care planning as a patient advocate to facilitate informed decisions about future health. We're going to call some terminology out, some of it which you've probably heard in second, which should be a brief reminder today. Advanced directives, they're going to vary from state to state, but are readily available through Caring Info online programs, such as the National Hospice and Palliative Care Organization. A durable power of attorney for health care, known as a DPOAHC, is not the same as a durable power of attorney for one's finances. That could be or may not be the same person, depending on who the patient will designate. The durable power of attorney for healthcare often is referred to as a healthcare proxy or a healthcare agent or a surrogate decision maker. Does not make healthcare decisions until the healthcare provider states that the person lacks the capacity to make his or her own healthcare decisions. This is usually resulting in impairment in cognition. The second part of an advanced directive is a living will, LW, which identifies what one would or would not want if she is near death. Cardiopulmonary resuscitation, known as CPR. We know that as artificial ventilation and artificial nutrition and hydration. A third part of the advanced directive is the DNR. Do not resuscitate or do not attempt to resuscitate. DNAR. Order that can be signed by a physician or an authorized primary health care provider, which instructs that CPR not to be attempted in the event of cardiac or respiratory arrest. Some states also have directives referred to as POLST, Physician Orders for Life-Sustaining Treatment. By law, primary health care providers in the United States must initiate CPR for a person who is not breathing or is pulseless unless they have a DNR order. We're going to briefly look at hospice and palliative care. Again, all of this information is coming directly from your book. Hospice is considered to be a model for high quality, compassionate care for people facing life-limiting illnesses or injury. Hospice uses a team approach, providing expert medical care, pain management, and emotional and spiritual support expressly tailored to the person's needs and wishes. Palliative care has been proven to improve quality of life during the end-of-life stage or the terminally ill, yet often comes too late in the course of the illness to be most beneficial to the patient and their family. PCCS's palliative care consultations usually occur more than 1 week before the individual's death. Research has shown that the value of palliative care for veterans experiencing earlier consultations with palliative care providers lead to more positive outcomes and higher satisfaction with end-of-life care. I do want to mention that the Medicare Hospice Benefit Services can be used as a guide for hospice care in the United States. This benefit pays for hospice services for Medicare recipients who have a prognosis of 6 months or less to live and who agrees to forego curative treatment for their terminal illness. Many patients who do not qualify for Medicare may have benefits through private insurance or government medical assistance programs, for example, Medicaid. In the last 15 years, twice as many older adults died in hospice care, as in hospitals, nursing homes, when compared with the previous decade. The goal of palliative care is to improve the quality of life for the patient as well as their families. An interprofessional team of healthcare providers include doctors, nurses, social workers, and the chaplain. They work together to address the unique needs that are associated with the serious and chronic illnesses. Palliative care consultants are provided in a large number of hospitals and on ambulatory care basis in some communities. If you take a look at Table 8.2, it's going to compare palliative care to hospice care. So we're going to look at assessment. We're also going to look at analysis, and we're going to look at managing symptoms and planning and intervention, okay? So I may have to move this slide around a bit to get all of the information included as we cover the content. So first, when we talk about assessment, we want to recognize cues. So how can we do that? We're going to obtain information about the patient's diagnosis, past medical history, and recent state of health to identify risk for symptoms of distress at end of life. People with lung cancer, heart failure, chronic respiratory disease are at high risk for respiratory distress and dyspnea as they decline. Patients with tumors near major arteries, for example, they're at risk for hemorrhage. And those who have often experienced pain often continue to have pain at the end of life, which may increase, decrease, or remain at the same level in intensity. So let's look at the physical assessment signs and symptoms. You want to assess the level of consciousness because oftentimes that's going to decline, which can lead to unresponsiveness as well as coma. As a coma, there's going to be cardiovascular dysfunction changes in the blood pressure where it may decrease, and often it's only palpable. The dying person's heart rate may increase, may become irregular. There's going to be changes in the breathing pattern that's very common. There may be periods of apnea. How many of you know what Cheyne-Stokes is? Apnea alterations with periods of rapid breathing are also common. As the patient's level of consciousness decreases, he or she may lose the ability to speak. You want to teach family and caregivers to watch closely for objective signs such as restlessness, grimacing, and moaning. Teach them how to perform interventions that can help relieve discomfort and stress as described in the patient and family education. So again, common physical signs and symptoms of approaching death with recommended comfort care measures. So see that box. You want to also assess for symptoms of distress in terms of intensity, frequency, duration, quality, exacerbating, meaning that the symptoms are worsening, and relieving factors, and effect on the patient's comfort when awake and sleep. You want to do a psychosocial assessment. Patients facing death may have fear or anxiety about their impending death with difficulty coping. We should assess their cultural considerations, their values, and religious beliefs as well. When we look at patient-centered care, cultural and spiritual considerations, at the end of life, many adults oftentimes feel challenged about their spirituality or want their spirituality to become a bigger part of their lives. Other patients who do not believe in an afterlife may still experience hope for a cure and a comfortable death. So when assessing the patient's spirituality at end of life, We want to use the classic phrase or mnemonic HOPE as a guide. The H stands for sources of hope and strength. The O is organized religion, if any, and the role it plays in the patient's life. The P is for personal spirituality, rituals, and practices. The E is for effects of religion and spirituality on care and end of life decisions. Families of people near death often manifest fear, anxiety, and knowledge deficits regarding the process of death and their role in providing care. We want to ask them if they want to talk about bereavement or grief. We can get a counselor who can help them, who can help guide them, or clergy. Now we're going to look at analysis, where we analyze cues and prioritize hypotheses. The priority collaborative problem for the patient near death or end of life is potential for symptoms of distress that will prevent a peaceful death. So, what is going to be part of our planning and interventions and how we generate solutions and take action? We need to consider the needs and preferences and acknowledge that are met, control or management of symptoms of distress, meaningful interactions with family and other loved ones, and a peaceful death. Interventions are planned to meet the physical, psychological, social, and spiritual needs of the patient by using coordinated interprofessional healthcare team approach to end-of-life care. Believe it or not, a large percentage of Americans would like to die at home. If this is the patient's preference, you want to work with them or the family. And we can also arrange for the patients and families to meet with hospice representatives as well. When medications are used, they are often scheduled around the clock to maintain comfort and prevent reoccurrence of symptoms. As we talk about managing their pain, pain is a symptom that dying patients fear the most, especially with some diseases such as cancer, osteoarthritis, muscle spasms, and stiff joints secondary to immobility. Non-opioid and opioid analgesics play a role in pain management near the end of life. We may see long-acting opioids, short-acting non-opioids used as well for pain management. Patient care that is centered for the older adult consideration. Some experts recommend symptom management at the end of life, which means discontinuing doses of opioids such as morphine when the patient has little to no urinary output. For patients with known renal failure, fentanyl should ideally be used from the start of opioid administration. Chapter 5 in your book provides detailed management of persistent chronic pain. The use of medical marijuana or cannabinoid-based medicines, known as CBMs, is increasing in palliative as well as end-of-life care. There are some complementary and integrative health, so non-pharmacological interventions are often integrated into the pain management plan. We may see massage. The thing you need to remember is that massage should not be performed over the site of tissue damage. For example, open wounds, tissue that is undergoing radiation therapy. You may see music therapy. It's another complementary therapy used by people near the end of life that is shown to decrease pain by promoting relaxation. Aromatherapy and essential oils can be used in conjunction with other treatments. We do want to manage weakness. Mechanical and electronic beds are often used to elevate the patient's head and promote air exchange. We may see the insertion of a long-term urinary catheter or Foley. Weakness combined with neurological function may also impair the individual's ability to swallow, and we know that as dysphagia. Most experts believe that dehydration is in the last hours. You may see terminal dehydration. To avoid dry mouth and lips, we often moisten them with soft applicators and apply an emollient to the lips. Managing breathlessness or dyspnea. Dyspnea is a subjective experience in which the patient has an uncomfortable feeling of breathlessness, often described as terrifying. Opioids such as morphine sulfate are the standard treatment for dyspnea near death. Bronchodilators such as albuterol, ibuprofen, bromide, by a metered dose inhaler may be given for symptoms of bronchial spasm. For example, if wheezes are heard, you may see corticosteroids such as prednisone may be also given for bronchial spasm and inflammatory problems within and outside of the lungs. Anticholinergics such as atropine, ophthalmic solution, or hypocasamine are commonly administered sublingually to dry up secretions. Oropharyngeal suctioning is not recommended for loud secretions in the bronchi or oropharynx because it's often not effective and it may only agitate the patient. There are some other non-pharmacological interventions, and that includes limiting exertion to try to avoid exertional dyspnea, inserting a long-term urinary Foley catheter to avoid dyspnea and exertion, positioning the patient with the head of the bed up, either in a hospital bed or a reclining chair to increase chest expansion, applying wet cloths to the patient's face, and encouraging imagery and deep breathing. We also want to manage nausea and vomiting. Other causes of nausea and vomiting that occur at the end of life can be uremia, where there is increased serum urine nitrogen, hypocalcemia, increased intracranial pressure, constipation or impaction, and bowel obstruction. If constipation is identified, you may see some type of enemas given to help remove the stool quickly. In addition to providing medications, you want to be sure to remove sources of odor and try to keep the room temperature at a level that the patient desires. Aromatherapy, such as using camomile, camphor, fennel, lavender, peppermint, and rosemary, and rose may reduce or relieve vomiting. We do want to manage agitation and delirium as well. Agitation at the end of life first requires assessing for pain or urinary retention. It requires us to assess for constipation or other reversible causes. If pain or urinary retention and constipation are ruled out as a cause, delirium, acute confusion, is suspected. When delirium occurs in the week or two before death, it is referred to as terminal delirium. When we look at complementary and integrative health, we know that music therapy may provide relaxation by quietening the mind and promoting a restful state. We may see pet therapy used, aromatherapy, and we do lastly want to manage seizures. Seizures are not common at the end of life, but may occur in patients with brain tumors, advanced age, and pre-existing seizures. Around-the-clock drug therapy need to be maintained at a high seizure threshold for patients who can no longer swallow anti-epileptic drugs or AED. We also want to manage refractory symptoms of distress. Patients receiving opioids from pain or dyspnea and other drugs such as antiemetics or anti-anxiety agents may experience mild sedation as a side effect of therapy. We do want to meet their psychosocial needs. The personal experience of dying or losing a loved one through death is often life-altering. Unexpected deaths, particularly in the young, tend to be the most traumatic. When a patient has a chronic life-threatening disease, he or she or their family may have some knowledge of the expected outcome. Whereas death and the termination of life, or the dying process, people facing death may demonstrate emotional signs and symptoms of their response to the dying process through behaviors to equate saying goodbye or through actual withdrawal. We do want to assist the patient during the grieving process. Grieving is an emotional feeling related to the perception of the loss. We may see mourning, which is an outward social expression of loss. Some patients and their families express grief openly and loudly, whereas others may be more quiet and reserved. There is Table 8.3 that lists the basic beliefs regarding death, dying, and afterlife for some major religions. Nursing intervention should be aimed at providing appropriate emotional support, allowing patients and their family members to verbalize their fears as well as their concerns. We want to intervene with those grieving by impeding death so we can either be with them as opposed to being there. Being with simply implies that you're physically and psychologically grieving with the patient, you're empathetic, you're listening, you're being present with the patient and the family is oftentimes going to foster trust, which can help build a therapeutic relationship. You want to accept whether that the grieving person, whatever it is the grieving person is saying about the situation. You may see storytelling through remnants of life. Review can also be an important activity for the patient who is dying. You may want to suggest that the patient and the family record audio biographies or stories or print videos or write their memories in a journal or even develop a scrapbook. And I know you all have seen some of those videos where the loved one has a box or a scrapbook that the individual turns to once they've lost their loved one. When assessing spiritual needs of the dying patient, you want to consider all of those end-of-life preferences based on cultural beliefs and practices. There are certain tribal ceremonies that must take place for some patients to have a peaceful transition into the spirit world, such as a good death. Smudging, that is, selected tribal medicines are often burned and smoked and passed over the patient's body to cleanse it. You want to stay away from a lot of those negative statements and don't try to explain the loss using religious terms. Saying things like everything happens for the best or God sends us only as much as we can bear. These kind of statements are usually not helpful when that person has yet to express feelings of anger as well as anguish. Quiet spaces can offer a place for them to respect or reflect or pray. Although it's very emotionally challenging, witnessing the death of a loved one may facilitate the family's acceptance of a death. In Canada, the Canadian Hospice Palliative Care Association can provide information to the patients, their families, lay caregivers, and volunteers, and members of the interprofessional healthcare team. When we look at evaluation and we want to evaluate those outcomes, evaluating the care of the client is based on the identified priority patient problem in end of life, evaluation is not related to the improvements in the overall condition. Rather or not, it's specific in promoting a peaceful death. The expected outcomes are that the patient with end of life care will have needs and preferences acknowledged and met, have control or management of their symptoms of distress, experience meaningful interactions with family and other loved ones, and experience a peaceful death. This next slide here is some of the patient and family education preparing for self-management. I'm going to try to get this slide together. One moment. So, common emotional signs of approaching death. You may see withdrawal, where the person is preparing to let go of the surroundings and relationships. The person may talk to people you cannot see or hear, and objects and places that are not visible to you. These are not hallucinations or drug reactions. Do not deny or argue about what the patient claims. Affirm their experience. You may see letting go. The person may become agitated or continue to perform ritual or repetitive tasks. Oftentimes, this indicates that something is unresolved or preventing the person from letting go. As difficult as it may be to do or say, the dying person takes on a more peaceful demeanor when loved ones are able to say things such as, "It's okay to go. We'll be all right." Saying goodbye when a person is ready to die and the family is ready to let go. Saying goodbye is important for both the patient and the family. Touching, hugging, crying, saying "I love you," "Thank you," "I'm sorry," "I'll miss you," are natural expressions of sadness and loss. Verbalizing these sentiments can bring comfort both to the dying person as well as those left behind. Now we're going to look at postmortem care. If the death was in the home and expected, emergency assistance should not call 911. If the person is with the patient and they're part of a hospice program, the family will call the hospice service. If the death is unexpected or suspicious, medical examiners are often notified. Otherwise, the nurse or the primary healthcare provider performs the pronouncement and completes a death certificate. Most states allow nurses to pronounce death in nursing homes and other long-term care facilities, but only a few states permits nurses to pronounce in an acute care facility such as hospitals. You do have a box on best practices in patient safety and quality, so review the pronouncement of death box. After a patient has died, you do want to ask the family and other caregivers if they would like to spend time with the patient to help them cope with what has happened and say their goodbyes. Some family members may find it therapeutic to bathe the person or prepare the body for transfer to the funeral home or the hospital morgue. Before preparing the body for transfer, you do want to ask the primary healthcare provider whether or not an autopsy is performed. When death is expected, usually an autopsy is not likely. An autopsy is generally performed only when the cause of death is unknown. Some religions such as Orthodox Judaism do not allow autopsies. So when we get to evaluation, evaluate the care of the patient based on the identified priority patient problem. We may see physician-assisted death, known as PAD. Sometimes it's referred as assisted dying or physician-assisted suicide, and it's gaining worldwide public support. Withdrawing or withholding life-sustaining therapy, formerly called passive euthanasia, involves discontinuing one or more therapy that may prolong the life of a person who cannot be cured by therapy. Another phrase sometimes used is letting the person die naturally or allowing unnatural death. Professional healthcare organizations and some religious communities support the right of patients and their surrogate decision makers to refuse or stop treatment when patients are close to death and interventions are considered medically futile or capable of causing harm. An alternative method for hastening death is called voluntary stopping of eating and drinking, and that's known as VSED or VSED. Many patients want control over their life and wish to die rather than continuing experiencing severe pain and suffering. Nurses are usually in the best and most immediate position to discuss these issues. In all cases, the principle of informed consent must be obtained or met. So, now let's look at the physical signs indicating that death has occurred. Breathing will stop, the heart stop beating, the pupils become fixed and dilated, the body color becomes pale and waxen, the body temperature will drop, the muscles and sphincters will relax, urine and stools may be released, the eyes may remain open and there is no blinking, and the jaw may fall. So you want to note the time of death, the time at which the family or the staff reported the sensation of respiration. You want to identify the patient with the ID tag if in a facility. Note the general appearance of the patient. Ascertain that the patient is not roused to verbal and tactile stimuli. Avoid overly painful stimuli, especially if the family members are present. You want to auscultate for the absence of heart sounds, palpate for the absence of a carotid pulse. Listen for the absence of spontaneous respiration. Document the time of pronouncement and all the notifications in the medical record. Document if a medical examiner needs to be notified. Document if the autopsy is planned for the attending primary health care family. And if your state and agency policy allows for RN to pronounce the death, document as on the certificate. So, best practices for patient safety and quality care, post-mortem care. You want to provide all care with respect and communicate that the person was important and valued. Ask the family and significant others if they wish to help wash the patient or comb his or her hair. Respect and follow their cultural practices for the body's preparation. If no autopsy is planned, remove or cut all tubes and lines according to your agency's policy. Close the patient's eyes unless their cultural or religious practice is for a family member or other persons to close their eyes. Insert the dentures if patient wore them. Straighten the patient and lower the bed in a flat position. You want to place a pillow under the patient's head. Wash the patient as needed and comb and arrange the patient's hair unless the family desires to perform the bathing and the body's preparation. Place waterproof pads underneath the patient's hip and around the perineum to absorb any increment. Clean the patient's room or unit. Allow family and significant others to see the patient in private and to perform any religious or cultures such as praying. You want to assess that All who need to see the patients have done so before transferring them to the funeral home or to the morgue. Notify the hospital chaplain or appropriate religious leader if requested by family or significant others. Ensure that the nurse or the physician has completed the signed death certificate. Prepare the patient for transfer either to the morgue or to the funeral home. Wrap the patient in a shroud or shroud unless the family has a special shroud to use, and attach identification tags per agency policy. This next slide is just a link to talk to you about organ donation and transplantation. So be sure to take a picture or snap this so you can pull it up and review over it. We will look at this in class. Here's another one on Honors Walk. So again, you can take a snapshot of it, try to watch the video on your own, or we will look at it in class. In summary, the nurse is present for the family, and loss can come in many forms. Grief can be expressed in different ways. Know the wishes of your patient and family. Establish a caring presence and use effective communication. We want to focus on improving quality end of life and its importance of the care of the body after death. This will conclude your lecture on grief and loss.